Welcome to MAP's inaugural Facebook live stream. My name is Chris Showalter. I'm the program director of MAPS. It's my pleasure to be interviewing and chatting with a friend of mine tonight, Darren Earnshaw. And in just a minute, I'll have Darren introduce himself and his history, his storied career as a physical therapist, both in the United States and Australia. Just a quick note. We have had a number of requests from people. I'm not able to make the live stream. Is there any way you can record it? The answer is yes. This is being recorded. We'll edit out some bits at the front where we're having some technical difficulties. And then we're going to post it on our research commentaries on our website. So you'll be able to go to our website, www.ozpt.com, click on research commentaries. If you're a current research commentary subscriber, you'll be able to see the video. If you're not current, you can sign up for research commentaries. They're free. They come out roughly monthly. It's a free resource for you. We look at interesting topics within orthopedic manual therapy, look at a particular paper or maybe two or three in a particular research commentary, give you hyperlinks to the original articles. We take a look at the abstract and then we have a chat about what's the take-home message from that piece of research. So again, and I'll mention this again at the end, you will be able to see a recording. You have to go to the MAPS website, ozpt.com, register for research commentaries, and it'll be posted there within the next 3 or 4 days, let's say. So without further ado, Darren Earnshaw, welcome aboard, brother.
Thanks, mate. I'm the inaugural one, I believe.
You are, well, pick the most important one first, right?
Exactly, I knew that. Fair
If
enough.
I went to England, I'd want to interview the Queen, wouldn't I? Right? That would be my number one pick, right? So, all right, mate, why don't you go ahead and talk about your history from first PT degree and the other things you've done.
Right, so I think I've been practicing almost 30 years, graduated back in 92 maybe. Bachelor's physio at that point in time. Worked for a few years, came to the States for a year, went home, worked another couple of years and did at that point in time what was a postgrad diploma in manipulative physiotherapy, which the guy running the course at that point in time was Bob Elvey. So I had the fortune of studying under him. Also, as a side note, doing his PhD at the time was Peter O'Sullivan. So we got to hear him. He's a bit of a rock star at the moment. And he presented some stuff. He's changed his tune a lot since then, which he'd be the first to admit. So I did that for a year. Then I came back to the States. Subsequently got my McKenzie certification probably around 2000, I think it was. And then only a few years ago, I went and did a fellowship at Washington University in St. Louis, learning the movement system impairment model, which is basically what Shirley Sahrmann sort of developed. So I did that. That was sort of a year. You would drive down there and do classes and a lot of online stuff as well. So, and currently working in an outpatient clinic in Northwest Indiana, seeing a lot of all sorts of stuff.
Brilliant, mate. You mentioned Bob Elvey, and to the older people like you and I who've been around the traps a bit, we know Bob Elvey well. But to some listeners and watchers who are here on Facebook Live, Bob Elvey was the inventor of what were called the brachial plexus tension tests. And what he did is he looked at cadavers and looked at what movements he could do to try and put tension on the nerves. So that really became there was a study that he did on numerous cadavers. And so he developed the original brachial plexus tension tests, which then went to become the upper limb tension tests, which are now called the upper limb neurodynamics tests or neurogenic tests. So that, sort of the lineage in that is Bob Elvey to back to Jeff Maitland, including Dave Butler and Michael Shacklock and Lorimer Mosley and others. So just, never forget the past, mate. Yeah. Right? Remember the big guys.
Bob regretted calling them tension tests.
I think he did.
Everybody says they've got positive neural tension. which makes no sense to me. It just means I've got a sensitive nervous system. You're using tension to test it. But so if you, by the wording of it, tension test, everybody thought I need to stretch nerves, which, you know, we can discuss that if you like, but doesn't really fit. So we wish he'd called it something else, which it has subsequently been called, hasn't it?
Exactly. A little bit like the clinical prediction rules. You know, when they got out and they were called rules, there was a lot of pushback against that, right? So now you're telling me what to do. Clinical practice suggestions maybe might have been a bit.
Well, that is, isn't that the new terminology for them? Clinical prediction guidelines or something, you know, just a guide, not a rule. Right.
Yeah. Well, let's go. So just for the audience, you know, our batting order here is we're going to get Darren to talk a little bit more about what he learned in the WashU Fellowship, the Shirley Sahrmann approach. And we welcome questions coming in on Facebook. And I have my lovely assistant Rosalie here behind me, who's going to help direct me to some of your questions. We'll get to them as we go through sections. So we're going to talk about Shirley Sahrmann. Then we're going to talk about Robin McKenzie's approach. Then we're going to talk about passive versus active approaches. And then we're going to present a recent case study of which Darren was a co-author on the paper. It's out in ePublish right now as of last month, so it'll publish fairly soon. And that's going to lead us into a discussion of the Maitland approach. And then time permitting at the end, we might compare and contrast the philosophies of using mobilization and manipulation. So enter your questions regarding the approaches as we have a chat and things progress. And the questions will be passed to me and I'll be able to ask them back to Darren. So Darren, Shirley Sahrmann's approach, Shirley's got a very storied career. I mean, she's a legend, an absolute legend in her own right. Yeah.
Yeah, one of the nicest people I ever meet too.
Yeah, she is. She's lovely. Very down to earth.
And hilarious as a lecturer, isn't she? She's just, if you haven't seen Shirley talk, you've missed out on something. But yes, so my Shirley story is that I had seen her a few times at AOMS presenting things. And I think she was talking about the hip or something. And I would, at that point in my career, which is probably over 10 years ago, I had the chip on the shoulder thinking I was pretty good at everything. And I would try to fit what she was saying about the hip into my paradigm of how I believed the hip worked and et cetera, et cetera. And subsequently, we did some courses where it was sort of like a Maitland, Sahrmann, McKenzie throwdown, where some McKenzie guys organised different patients for, I was the Maitland guy, there was a McKenzie guy, and Shirley was the Sahrmann guy, which was a bit intimidating. That's the first time I ever actually met her. So I had we all had separate patients, and my patient was a guy who was a runner. He had sort of unilateral back pain, low down, would come on at the 5K mark at a run. So up I get, and I'm sitting, I'm trying to find this comparable sign, as we do like to find, and I couldn't find it, anything. I quadranted him, repeated quadrants, repeated movements, combined movements, you name it. Palpated the hell out of his spine, wasn't particularly tender down there. I said, is this where it hurts? He goes, well, that's where it hurts when it hurts, but it doesn't hurt at the moment. And I said, well, I've got this theory. He basically, I think he told me he'd fallen off a bar stool or something and it injured his back. So I thought he had an injury, maybe it had stiffened up. When he ran, after a while, it aggravated him. So I'm pushing on his back because I got nothing else up my sleeve at that point in my career. And I say, I think it's stiff. It's, it fits into my stiff paradigm, low irritability, stiffness. And then I sort of said, but Shirley probably thinks something else. And she looks up from her computer because she's always on the computer. She goes, yes, he moves too much there. And I'm like, what are you talking about? I actually didn't really understand what she was talking about. So over dinner that night, I said, yeah, I said, he sounds like more like one of your patients, doesn't he? A movement impairment sort of driving this type thing. So she looked at him the next day and found a whole bunch of stuff, which I had no idea what she was doing. So I thought to myself, I need to learn more about this, because as a manual therapist, I think we're really good at assessing passively. And I'm just talking about myself at that point in my career. I wasn't that good at assessing muscles. I wasn't that good at assessing the way people moved, etc. And I just found their system interesting. So I thought I'd better do a fellowship if I'm really going to learn what they're on about. And it all fits, actually. After doing the fellowship, the Maitland stuff, the McKenzie stuff, it all fits together, because it just depends on the patient, basically. And what she was saying with this particular patient was, due to some impairments, which I can't remember exactly what was going on, he was weak in glute med and stiff here, according to her. As he ran, the impairments were setting up overload of his lumbar spine. So I think they would have diagnosed him as extension rotation problem. So as he's running, he's getting too much extension rotation at that segment. He gets irritated, he gets pain. So you have to correct the things that drive that impairment. And their diagnostic system is, they name the impairment. So they name, it's an extension rotation syndrome, or in the shoulder, it's an anterior glide syndrome, and things like that. Now, having done a fellowship, I'm still like a complete amateur at it. So if I mess up and there's any representatives of WashU, please forgive me, basically. But it was quite an eye-opening thing, and I've picked up lots of good things from that fellowship, which I plug in. And nowadays, when I treat patients, I'm always thinking, even if I find something, you localize the source tissue, why is that source tissue irritated? Which then makes me start looking at different things as to what's irritating. Now, sometimes they've just stepped in a hole or been hit by a car, and what irritated it was the car, and they get to you at 6 weeks and you just really need to clear out a joint or whatever. But with chronic patients and also sort of acute patients, you can plug this movement system in really effectively to sort of complement. Sometimes it's the dominant thing, and at other times it complements a manual therapy thing, just as manual therapy sometimes complements that system. So I find nowadays, at the end of my subjective, I can sort of decide where I want to weight my assessment a little bit more. Or my treatments, I sort of think, you sound more like the runner. He would have been more of a movement impairment problem. I could have sat there doing unilaterals on his lumbar spine till the cows come home. But if I didn't clean up those impairments, every time he went for a run, he was going to have a problem. And he did benefit from manual therapy, though, because the therapist that brought him in said that, they did strong rotation techniques, etc. It helped him, but it just wasn't clearing it out. And the other thing I learned from that guy was, he had told me I fell off a stool, blah, blah, blah. So I thought, okay, that's a mechanism of injury, and I moved forward from there. But that night over a beer, he says, yeah, but I'd had the problem beforehand. So it completely changes your clinical reasoning, doesn't it?
Sure.
So it just demonstrates, if in your subjective you miss something like that, which I did, it can completely take you down the wrong path. So it just, my thing is, if you can't do a good subjective and get all the data, you're sort of floundering around. It doesn't matter how clever you are at clinical reasoning, you got to have some data to start with. And when I was in the fellowship, teaching in the fellowship at the University of Illinois, we would see these students come in and they would do such a short, sharp subjective, probably because they're under stress too, but they just floundered by doing such poor subjectives. I was like, this is just illustrating to me how important the subjective is. To me, it's everything should be there. Just about 90% of what you think's going on should be at the end of the subjective.
Yeah, well, Jeff Maitland said that at the end of your subjective exam, he said 85%. At the end of your subjective exam, you should be 85% sure where to put your examining finger.
Right.
And I concur with that. Obviously, I trained under him, so I'm a bit biased. But, the point is that there's so much value in the subjective examination because it guides the rest of your assessment.
Right.
And when you come back, whether you're having a beer in the bar with the guy later on and you delve deeper into that, tell me more about falling off the stool. Oh yeah, but I had the problem before that, and sometimes patients will come in, you say to them, have you ever injured your neck? No. Do you ever fall off a horse or off a bicycle or out of a tree? No. And then you treat them and then they come back the next time. They say, well, I've never injured my neck, but I fractured my C5 vertebrae, whatever that means.
Right.
So, to me, at my stage, I got a couple more years than you, but not much. The most interesting part of the clinical intervention component is the subjective examination, because to me, it's kind of like an Agatha Christie novel or, a Special Victims Unit or CSI Miami, whatever. It's a game of Cluedo. It's a game of finding out what's going on and asking questions in a non-biased way that allow the patient to truly explain what they're talking about.
Of all the subjectives, exams you'll see out there, the Maitland's method is probably the best I've seen. And actually, I was at dinner with Shirley once and we were talking about this and she just laughed and said, oh, Maitland people, I almost go to sleep listening to them do a subjective just because we get so much into stuff. And I sort of had a bit of a chuckle when I said to her, well, remember that guy, basically if we didn't get that piece of information, or I would have, she tends to treat everybody in her system, everybody that walks in. I don't.
As we all do. We all have our biases,
So what I sort of have a mix of systems. And what I find at the end of the subjective, I'm starting to think, well, this guy sounds like he's more of a manual therapy dominant treatment approach, or this guy's more of a Shirley's sort of MSI approach. And since doing some courses with Peter O'Sullivan quite a long time ago, I get a lot more into that psychosocial questioning that I never used to. I now ask them, what do you think's going on? When they told you your MRI, you had a disc bulge, what did you think? And then you identify that little subgroup of patients who are catastrophizing and having maladaptive thoughts. And sometimes the primary treatment for them is to start talking to them about various things.
Sure.
You use all the other stuff, but I like to sort of identify, who's going to probably respond the best to certain treatments, even though I think predominantly most of my patients get a bit of a mix. They're going to get some hands-on, they're going to get lots of exercises, and they're going to have me talking to them consistently about pain and all that sort of stuff.
It's that biopsychosocial approach to the patient. It's not.
The psychosocial, I have to admit, I wasn't that good at. And after watching Pete do some of his stuff with people, that no one was getting better. And I started asking those questions. It is mind-blowing the stuff people will tell you. And, and how it changes your treatment approach. Even if they are a rotator cuff post-surgery, which is pretty obvious what's going on.
What, from the scar?
Yeah, some of them you
never. The steri strip's still on it.
Yeah, you can never succeed with them unless you get into their brain and see what they're thinking, especially a bit later on, obviously. And they won't do the exercises you want them to do if every time they get pain, they think they're tearing something up. So you've just got to identify what are they thinking is going on, and is it going to hinder the way they go? And chronic pain is such a complex sort of animal to treat but we were discussing this the other day. What I think is happening nowadays is that it's the era of the psychosocial, and it's almost like the bio got forgotten. My thing is, do a good assessment, use your common sense, don't just go for the latest fad, fit it to where it fits. If it's psychosocial, I agree, do psychosocial. If it's bio and it needs a bit of whatever, then that's what you should do, and don't spend half your day talking about pain.
You're so right. And then the other thing that you've touched on, which I wanted to jump in on, was this issue in the subjective. The first question that most Maitland therapists, for those of you on the meeting who aren't aware of this, The first question a Maitland therapist asked is really quite open-ended. Hey, Bob, as far as you were concerned, what do you think is your main problem? I didn't ask you what the doctor said. I didn't ask you what the MRI shows. I want to know what you think your main problem is. And as you know, Darren, that sometimes that's like opening up a huge can of worms, because it's a very different thing than the prescription that came in on a little piece of paper, you know?
And sometimes you'll get people who come in and whatever the prescription was, it's changed. You know, it's like my back was the main problem, but now my neck's killing me and my back's not worrying me. And I see therapists go, oh, well, I can't treat you because the script says this. And I just go, well, that makes no sense.
Yeah.
You know? And I mean, in today's environment, we're a bit more direct access. You can change track. I mean, I remember back when I came here 20 years ago, you'd have to call the doctor up and say, can I treat their neck now? Because actually their neck's bothering them more just because of the stupid medico-legal stuff. But yeah, it's 9 times out of 10, I see a lot of spine. They all tell me about their MRI findings, which is automatically a sort of flag, isn't it? That there's something psychological, not psychological, but you're going to have to address something. So you have to get more into that at some point in your eval.
And my thing's to be honest with them, you know, and say, look, you know, the MRI findings are often picking up things which are incidentalomas.
Yep.
You know, it's a little less esoteric thing, which probably has nothing to do with what's going on with your problem.
And then, you know, it's interesting though, mate, you sit there, I've spent a long period with patients trying to unwind that stuff. A flippant remark from a physician.
Yeah.
Basically, I can never unwind some people.
Right.
It's just so, I just wish the medical community was more aware, because I think PT's on the ball on this, of how important your wording to people is. I don't have a problem, for instance, with if someone wants to believe in an osteopathic approach to treatment and they do whatever it is and it gets them better, fantastic. But please don't tell them you're out of alignment, or, you know, don't describe things that then catastrophize them and they become dependent on you and all this sort of stuff. So,
you know, the place that I often pick up a lot of the pain science and CBT stuff is in going through Jones and Rivette's 8 clinical hypothesis categories.
Right, yeah.
And right at the start, what are the restrictions and what are the capabilities?
Yep.
And when you the answers you get and the way you get them often give you an opportunity to identify the catastrophizers, the people who need a bit more information, a bit more clarity, the people who need a bit of a push, you know? So, you know, what's your restriction? I can only walk 2 blocks. I can only walk 2 blocks because my knee hurts. All right, what are your capabilities? Well, I can walk a block. All right, great. So let's use a block as a positive and aim to get to 2 blocks, right? And I'll help you work through it. But also, you know, in the subjective exam, you know, as Dave Butler says, you know, his friends who are psychologists and psychiatrists say that, you know, you physios have a marvelous opportunity because you can actually touch your patients.
Right.
You can actually palpate the shoulder and have them focus on the shoulder while you're palpating. You know, psychiatrists and psychologists are not meant to touch them.
Yeah. I was chatting to Pete at one of the conferences about that, and he said he would do these conferences or whatever, and I think it was Stephen Linton, who's a good psychologist guy on pain. There'd be him and there'd be Pete, and Pete would say, the advantage I've got is I can tell them, listen, you don't have to worry about your disc in your back. It's not going to explode or whatever they think is going on. But then he can give them a movement strategy that they then do, and there's less pain, and they buy in. So
brilliant. Yeah.
We sort of fit into that sort of nice little niche, because there's a bit of a debate on how much we get into the psychosocial stuff.
Right.
And again, I don't want to take them back to their childhood and how their mother and father treated them or whatever. but I do want to know what's going on in their head, and then I can sort of demonstrate if I identify it as a problem. Hey, listen, I know you can't bend over when you're in standing. How about you sit down and you try to touch the floor? And it's like, well, that's low back flexion. That's flexing your back and it didn't explode. Let's try quadruped. Let's try this. Or identify that group of people where they're overusing their abdominal muscles. So they're consistently sort of on, which blows everything up and so you try to relax them as they do these movements. So it was interesting what he was saying about that sort of stuff.
So that's good, mate. Let's move on and talk a little bit more about the McKenzie stuff, because the audience have been given sort of a profile of what they expect to get for their free video tonight, right? So let's talk about Robin McKenzie's stuff from your perspective, and I'll jump in as necessary.
Right. So I just look at, when I tried to merge it all together to make sense to me, I'm not a big fan of guru-based stuff. And the McKenzie guys definitely have a language, derangements and D1s, and I can't even remember half of it, to be honest with you. I just look at it as movement. But where they rock is repeated movements. Whereas in the past, I would extend someone or flex someone and they go, that hurts. Okay, great, got my comparable sign. We won't do any more of that because that hurt. Now it's like, we'll do more, do more, do more, do more. Right. And things change with repetitive movements. And the centralization concept's useful, but I would like to just say it's not written in stone, because often on courses we'll palpate someone who has pain down the back of their leg. You palpate the lumbar spine and they go, there's my pain. And then we'll sit there and go, okay, non-irritable, chronic, we can hammer that. And people are like, but it's not centralizing. It's like, well, it doesn't. In that case, I don't have a problem peripheralizing it, because I want to get stuck into the area and I'm picking higher grades and et cetera, based on a slightly different model. However, I do, you know, you can sort of integrate the way they think, not bad with what we do. They do their repetitive motion way better than us. I've got to admit, they go often beyond what I would do, because I get a bit nervous, or if I start to see them blow up, I'm like, I'm going to stop. And I've seen guys keep going and things change amazingly. Right. They sort of, so I don't really see it as being that different. It's just moving people. I don't think it's like, when they do sort of the classic prone press up, I just see that as repetitive passive extension. I could lie them on their side and do a manual therapy technique, but it's bloody hard work, and I'd rather have the patient do it, and it allows them to go home and do something. However, there are some patients who would not do that, and you may want to lie them on their side and start them off with some passive extension just to relax them and have them see that with repetitive movement, things change. So I think way back in the day, I used to think when I was a new grad that McKenzie was prone press ups and Maitland was you find somewhere and you poke on it. So they're all a little bit more complex than that. So I found it really useful, and I find it especially useful, just personally speaking, in the lumbar spine. If they fit that box, if you repetitively move them in a certain direction and they get centralization and they fit that derangement model, they also have a dysfunction category as well. If they fit the box, it works very well. Often it's very similar to what we do, but there's a lot of patients that it does not work on. So I don't want to just become only do MDT guy.
I'll be the devil's advocate here. You know, I went and studied in New Zealand with Robin McKenzie in 1988, right after I graduated college, because he first published his story of Mr. Smith, the man who was in long, you know, the table was in long sitting, and he told the guy to lie down on his tummy. He went and grabbed a cup of tea, and he came in, the guy was all lean back in extension. And he thought to himself, what's this idiot done? My goodness, what's going to happen, right? And this is an interesting point, because he recognized, because the patient said, my pain's gone away. And Robin had the foresight, and it was a different time too, that he recognized a clinical phenomenon, and he was able to write it up as a case study, right?
Right.
much, much harder these days to write up a case study like that. You need to have your patient-specific outcome measures. You need to have your heavy stats. It's not just a t-test anymore. And what's the sensitivity and specificity of that test you used? I've always thought that there really should be two branches of physiotherapy research. There should be the obligate clinicians who recognize phenomena in the clinical practice and then communicate that to the obligate researchers, to like Chad Cook, to our mate Chad Cook, and say, Chad, this is what I see in the clinic. I don't know what's going on. Can you design a study so we can evaluate it and see what's happening? And that's sort of the best of both worlds. The other problem with the research these days is trying to get an IRB somewhere if you're an independent and you're not hooked up with a university. It's very hard. I don't know if the audience knows, you can buy an IRB. You can actually, there are commercial services that'll do it for between $4,000 and $7,000. They'll write up an IRB for you and you can submit that. But then not all journals will accept it. But the other thing I wanted to say about McKenzie, I use McKenzie a lot. I find McKenzie far more applicable in the lumbar spine than it is in the cervical spine.
So do I.
Right?
Maybe I'm doing it wrong, but I still, again, if someone fits the box, it works well. I just don't find as many people fit the box in the neck.
Well, so the pathology of discogenic issues in the neck is quite different than in the lumbar spine. And I'll reference the work of Sue Mercer, who's an anatomist and what we in Australia would call a manip physio or a advanced practice physio in manipulation and mobilization and movement science. She actually did a PhD dissecting, and this is an old study. This goes back to like 2000, guys. She did her PhD on this, and Nikolai Bogduk was her PhD supervisor. And then they wrote a paper about her PhD. And she found that the nucleus pulposus in the cervical spine in cadavers, and the median age of the cadaver was like 52, which is actually quite young for cadavers. Most cadavers are elderly people who donate the body to science. And when you do cadaver work, you end up with fairly old tissues that have a long life. Some of hers were actually quite young. I think the youngest was 12, and she had a couple of 18 and 20-year-olds. So, but what she found is that the classic example of the, 10 to 12 rings of annulus fibrosis offset at 65 degrees, and then the nucleus pulposus inside, and it's jelly-like in substance, and all that stuff that we think of in terms of the old days. Try not to talk to the patient about this too much because it just gets too confusing for them. But they found that the nucleus pulposus in the normal cervical spine, all these patients, all these cadavers did not die of traumatic cervical injuries. They died of a stroke or a hemorrhage or after surgery, but they didn't have a trauma to the neck, no known trauma. That the annulus fibrosis was enormous, like 80% of the diameter of the disc itself. That was the annulus fibrosis, and it was fibrotic in nature. That it's actually very tough and tight tissue. It's not, if you've dissected out a disc in a cadaver, it's not this wishy-wobbly thing that's floating around. You really have to get in there with a scalpel and dig at it to get it out. And that there were differences in the fibrotic, in the rings, in the annulus fibrosis. Because there's an orientation that goes all the way around to the uncovertebral joint, and then there is no annulus fibrosis at the uncovertebral joint. And the question is, it's a chicken or the egg question. Do people not have an annulus fibrosis because true lateral herniations in the neck are uncommon? Just the body's being efficient, it doesn't need the tissue, so it doesn't put it there. Or do the annular changes degrade over time? And I'm not sure we know that. But the clinical presentation of a cervical disc is very different to the lumbar disc, because the cervical disc seldom has an event. Seldom do people say, I turned my neck and I got all that pain. Unlike the lumbar patient who says, I bent over to pick up the box, I twisted, I heard this pop, I had this loud, this terrible stabbing pain in my back. And I recommend you guys go, and I'll post this I'll post some links to the studies underneath this video on the ResCom version of this video. But they talk about how the actual herniation, the bulge and herniation of a cervical disc is kind of like glaciation. It doesn't just happen quickly. It happens progressively over time. And then at one particular point, it becomes symptomatic and people seek treatment.
Yeah. So, I become less worried nowadays about what's actually happening versus just do your eval, and it goes back to that brick wall thinking that we talk about in the Maitland system, where I would love to know the reality of how everything in the body works, but we're not there. So whilst I try to fit everything that I know anatomy wise, half the time you just got to go by, hey, if I do this repetitively, it centralizes and feels better. And then you're like, well, that doesn't fit the rules that I learned at school. I'm going for it just feels better type problem.
Sure.
And the McKenzie guys had problems initially. I don't know what they're saying now, but that disc model in the lumbar spine, anyway, like their explanation that they were reducing it and things like that didn't really pan out from my understanding with the literature. They had people do all these repetitive movements and they re-MRI them and the disc is pretty well looking the same.
Right.
Now it does move because in the McKenzie courses, they show a cadaveric section and they move it back and forth and you can see the nucleus going dunka dunka dung. But my thing was always, well, as soon as they go back to neutral, it's right back where it was. But it works. The repetitive, let's say your classic McKenzie guy, they have unilateral pain on that side down their leg. They do repetitive extension, it centralizes, and it seems to work. Now, the big argument nowadays, which I see on Twitter all the time by all the millennials who know everything, even though they've been out 2 years, is it would have just got better on its own, which I heard senior faculty of McKenzie saying, if all you did, which is part of the McKenzie method, was have better posture, teach them the posture stuff, because, a big part of the McKenzie stuff is don't slouch, sit, keep yourself in a sort of position that's pain easing, and don't re-injure it, bending forward and all this. If you just did that, they'd probably be better in 6 weeks. You don't have to add all the special exercises. Although I do believe there is a subgroup where you do, but it sort of makes sense. You just don't re-injure the area and the body does its own thing.
Can I jump in there for a second, mate?
Yeah.
So a fairly influential physician called Hippocrates said that most low back pain resolves in 45 days.
Right.
And that was back in, X thousand or, just post whenever it was, it was BC times. Or
was
before
he around Socrates' time, mate?
Yeah, around about that time.
That guy who said the life not examined is not worth living. Is that the one? Yeah. So all these guys on Twitter that are sort of telling me that they're the first people to have reflective thinking and blah, blah, blah. There was another guy called Socrates that did it before them, I believe. Yes.
Yeah. One of my favorite comebacks when people say, I invented this new technique. And I say, all right, show me your technique and I'll tell you what we called it 40 years ago. Right? Yeah. There are no new techniques. I mean, the bone setters in England and Hippocrates and, 5,000, 3,000 BC Chinese and 2,000 BC, Mesopotamia and the Turks 1,000 BC, so.
But I do think we are better knowledged up on how it all works together to pick the right technique. But
that's why I think people should take a broad range of courses from different areas to broaden their horizon and understand, because there is no technique that fits every patient.
Correct. That's why I sort of don't like saying, I gave them McKenzie exercises, because I'm pretty sure at some point in time, someone else was giving them those sort of exercises too, but he definitely you know, there are landmark guys who develop systems that sort of push the profession forward significantly. What are you sticking your head in the white curtain for, mate?
Yeah, no, I'm sorry. Rosalie just informed me that Jeff has asked a question on Facebook, which is, do you have any tricks in your book to dissuade the patient away from negativistic language that the physicians might have used about the MRI and stuff? And can I jump in, and then I'll give you a moment to think about it, and you jump in? I show them the study by Brachial in 2016. It was a retrospective study of MRIs, 3,110 asymptomatic low back pain patients with MRIs. That is, they were in, and this was a Russian study, they were in the hospital being MRI'd for abdominal injuries, for colic, for GI problems. And no one even looked at their spines because they weren't an orthopedic patient. They were a GI patient. And then this group, Brachial et al. In 2016, went back and took a look, and they looked at all these asymptomatic findings in the lumbar spine, and they found that basically 30% of 30-year-olds have one or more bulging disc. When you're in your 50s, about 60% of people in their 50s have facet osteoarthritis. Well, no kidding. That's called wear and tear. Babies don't have osteoarthritis in the womb. It happens every time, you know, once you're a victim of gravity, OA starts to set in. Obviously, it's worse if you're a running back for a professional football team. That's going to accelerate stuff. But I'll also post that on this ResCom. I'll post the link to Brachial so that you guys can go take a look at that. But I have that, you know, I have that as a slide in a number of my slideshows, and I have it printed out as just a single page, the slide, and I just go through it with them. And I say, how old are you? You're 65. Okay. This is your percentage of spondylosis. This is your percentage of facet. This is your percent of spondylolisthesis. This is your percentage of discogenic problems. And these were all asymptomatic people who didn't have back pain. So I'll throw it to you. So, you know, detangling some of the language that they've learned from referral sources.
First of all, I think you've got to sort of look at the patient and sort of work out where they're at as far as what sort of explanation they need. Like some guys I treat, you'd be wasting your time giving them an article because they're never going to read it. They won't understand half the things you're saying. So you've got to sort of make it simplistic. Whereas if you had an engineer or something, he would appreciate you giving them an article, that because if you just telling them is not enough, they need to see it in the literature. Right. So you can have all sorts of stories to tell them. You know, you tell them you drag 100 people off the street, 30 have disc bulges and have no pain. Therefore, we know that the disc bulge that you do have could settle down and still be there and you'll have no pain. So you've got to come up with your stories. I've got some for rotator cuffs. You know, if you have a piece of rope and you nick it with a knife, you can still pull on it and lift the whatever out of whatever. It's the inflammation that hurts. So what we're going to do is settle the inflammation. So you have all these explanations that stories for different body parts that fit your patient's sort of understanding. Things like grey hair of the back. You know, we all get grey hair as we get older. And it's not a catastrophe. Well, for some people it is.
Not for you, mate.
No, it's not.
A lot of hair you have to worry about.
That's exactly right. But yeah, there's a lot of stories that you can tell. And actually, if you do a lot of the pain neuroscience units, Butler's and Adrian Lau and that, they have a lot of stories on, just simplistic stories that patients appreciate. So I highly recommend that sort of stuff. But
and the other thing on that one is the book Explain Pain.
Yep, that's great.
I have a bunch of those books in my practice, and what I do is I lend them to patients.
Yep.
I say, listen, I'm not selling it to you. Huh?
It's almost too complex for some patients because there's some guys, man, I just have to dumb it down for them basically. And if it's not quite the reality, if it goes in their brain and gets me where I want to get, then I'm going to get there. That's fine. So one I do like is with discs. I say, well, what happens when you sprain your ankle? It blows up like a balloon because there's swelling. Your disc is the same. It it's swollen, it's painful, it's irritable. But over time, just like your ankle shrinks, that disc bulge is going to shrink. And there's good evidence for that. And they like hearing that sort of stuff. They're like, oh, okay, there's hope for me yet, sort of thing.
And there's good evidence that movement helps to resorb that disc too, whether it's a repeated movement or whether it's an external mobilization applied by the therapist.
Yeah.
So, you know, I seldom say always and never. I always do a Maitland style in-depth assessment. And even in complex patients, if it takes half an hour, so be it. If a complex multifactorial patient with pain in the neck and the shoulder and the elbow and the wrist and the hand and on the border, I really need to dig into that to find out what's going on, because I need to find where the core of the problem is. That's where I want to treat, right? I'm not going to ultrasound the older border of the hand because they said they got pain there, right?
Well, my classic story from when I was doing my fellowship was I had a patient like that. And in my mind, I'm just like, oh, you're just a chronic pain patient. You know, she'd had it for years. So I did a pretty weak eval, and I step out to get my feedback after I think it was the subjective. Got reamed by Peter Fazy, who's a prominent PT guy. Destroys me, says, get back in there and do your eval. Just go through the motions. Found a joint, mobed it, and this woman's like a miracle. It was amazing. Whereas I was going to just be like, well, you know, here's some exercises or something like that. I can't remember what I was going to do. But it's interesting. Shirley will say she does her entire assessment, doesn't miss one single test. She has a very systematic assessment, because she says as she goes through, she thinks she's got it at, let's say, the 25% point. And then something pops up and she's like, oh, I had that completely wrong. And she goes down a different track. So if you're not thorough, you can miss things. Right. So don't make assumptions is what I'm saying. And often even the chronic pain patients who you do end up having to treat them like more of a psychosocial person, I would always make sure you do a good typical Maitlandy sort of type assessment so that you're not missing something obvious that someone else hasn't sort of seen. Yep.
Well, I think it's time to move on because we've got a couple other topics we want to talk about. So what I want to do now is I'm going to do a share screen, which everyone will be able to see, which is actually the current research commentary that we're using. Can you see that, Rosalie?
Not yet.
I can.
You can?
Mm-hmm.
Just hold on, everyone. Sometimes it takes a few minutes for
now it's up.
Facebook Live to boot up. There's a bit of a time delay, like 5 or 6 seconds.
Yeah, it's up now.
So, all right. So, listen, guys, I brought this up because, first of all, because Darren's one of the people on the paper, one of the co-authors on the paper, and it's a really quite an easy case when you assess and treat accordingly. So this is research commentary number 81, January 6th, just published it the other day. Post-cervical fusion case study. The use of joint mobilization to adjacent segments, adjacent to the fusion, improves pain, function, mobility, and abolishes central sensitization. I won't go through the paper in depth, other than to say that the primary author is Robert Lebeau, who did this as part of his research component of his fellowship. The other two authors are Steve Schaefer and our own inimitable Darren Earnshaw. And it's entitled High Dose Cervical Mobilization to Improve Central Sensitization for a Patient with Post-Fusion Neck Pain. It's physiotherapy and physiotherapy practice, 2021. This is online ahead of print. Again, if you go to our website, ozpt.com, sign up for research commentaries, you'll get this, you'll get access to the other 80 of them, and you'll also get the new research commentaries as they come out. So the case description is pretty straightforward. A 63-year-old man with a 2-year history of unresolved neck pain, post-cervical fusion, presented to therapy with an exacerbation of neck and left shoulder pain. He presented with cervical impairments and intervertebral hypomobility. That's not measured by any particular tool other than the human hands and someone trying to find where is R1, the first onset of resistance, And where is R2, maximum resistance? That requires someone who's skilled in examining necks. Hypomobility above and below the fusion site. He had a high NPRS of 8 out of 10. He demonstrated marked loss in cervical mobility. He had indicators of central sensitization, including both hyperalgesia and allodynia. And they used high-dose cervical joint mobilization for durations of up to 10 minutes per treatment. Treatment was applied for 12 sessions over 4 months. I'll give you the results further down. And in the research commentary, I asked the question, what does this paper add to the evidence? And I think it's important for those of you who read papers to understand this, that numerous previous studies that look at non-thrust or mobilization, either as a standalone intervention or as a comparator, typically use what has become this de facto protocol, and you'll read it in a lot of papers. One bout of 30 seconds of mobilization equals the mobilization intervention. And the problem is that this so-called standardized or de facto mobilization intervention is often prescriptively applied in the research studies. Now, those of you who are research geeks know that prescriptive studies give you greater internal validity within the study. But in reality, one bout of 30 seconds of mobilization is not how mobilization is pragmatically applied in the real world. You will also, within this study, on the ResComs, be able to link to an earlier research commentary, number 56, called Mobilization versus Manipulation for the Neck and Back Pain. Is there any difference? Well, it depends upon how you study them. What I want to point out in this study is that the pragmatic, in this case study we're presenting, pragmatic clinical use of non-thrust mobilization begins with a trial of lower grade mobilizations, 1s, 2s, and 3s per Maitland. And the effect of the intervention is immediately reassessed using at least one subjective variable, normally pain, and one objective variable, usually range or a movement component. Progressions to higher grades is determined by a number of interdependent factors, including the patient's response to the initial mobilization, the therapist's clinical hypotheses, clinical reasoning and intent, and a due consideration of SINS. And I'll just go through the SINS mnemonic very quickly for you. Maitland's SINS mnemonic should be there in your screen. Severity of the condition. Irritability, how much activity causes how much symptom response, how long does it take to settle down. Irritability is the body's response to a movement or a posture or something they do. It's not measurable by MRI or by blood test. The nature of the disorder, what do you think's going on? The stage of the disorder, is it acute? Is it acute on chronic? Is it chronic? Is it an exacerbation of a chronic condition? And the stability of the patient's disorder. One of the key features of the LeBeau study is the use of longer duration mobilizations, high dose. And as we said before, up to 10 minutes of mobilization in one treatment. So let's take a look at what LeBeau did. In treatment 1, now remember, this is a C5-6 cervical fusion. In treatment 1, he treated C7, didn't treat the fusion, he treated below the fusion. And he used a unilateral PA, which is the photograph of the top photograph over there on the right. He used a unilateral PA, grade 3 for 3 minutes. He reassessed, he did more grade 3 for 4 minutes. He reassessed, he did more grade 3 for 3 minutes. In other words, total minutes, total treatment. That was treatment 1. Treatment 2, he went to the lower level, to the upper level, to C4, above the C5-6 fusion. And he did a unilateral PA there, grade 3 and grade 3+. And then he added passive physiological rotations as a component, or PIVMs. And he added cervical self-stretching techniques, etc., as a home exercise. That was treatments 2 and 3. Treatment 4, 5, and 6, he treated both C4 above and both C7 below the C5-6 fusion, using grades 3+ and 3++ for 5 minutes each. He then engaged T1 through 4 central PAs, and that's the middle shot there, thumbs pushing over the young lady's sports bra, central PAs in the thoracic spine. And he added deep cervical neck flexure training, and he added it as a home exercise. Treatments 7, 8, and 9, He continued his cervical UPAs and his thoracic central PAs, and he added ULNT2, the median nerve test, pictured at the bottom there of the screen, as a neuromobilization testing. And treatments 10, 11, and 12, which were 3 visits over 12 weeks, he was promoting exercise, assessing recovery, and ensuring that the patient had integration of their movement into activities of daily living. And what I really like about this study, it's a very clean progression through the Maitland grades based upon his assessment and based upon the patient's symptomatic response. I want you to note the mobilization progression of grades over the course of treatment. Started with a grade 3, then went to a 3 to a 3+, then a 3+ to a 3++, then a 3++ and a 4+. So what were the outcomes in this study? We've got the outcome measure in the left-hand column, and then we've got 4 columns off to the right. Evaluation, visit 6, visit 9, visit 12. NPRS started at 8 out of 10. At the end of treatment, it was 0 to 1 out of 10. Cervical left rotation, active range of motion, went from 30 degrees to 70 degrees. Cervical right rotation went from 35 to 70. Cervical extension went from 10 to 40. Cervical flexion from 20 to 30. The ULTT2A was positive at 25 degrees initially. Then it was positive at 90. Then it was negative at 130. And now that it was negative at 130 and all effectively normal, it wasn't assessed on the final treatment. And importantly, their NDI, their neck disability index, a measure of how disabling this condition is for them, went from 38 out of 50 to 5 out of 50 with joint mobilization, etc. The mean pressure on pressure pain threshold using algometry went from 165 down to 43 on the affected side, and went from 165 down to 40 on the unaffected side. The patient had allodynia at the beginning, which was still present at treatment 3, but then was absent for the rest of the treatments. And the deep neck flexor endurance that the patient could properly control was 2 seconds at baseline and 20 seconds at the end of treatment. So what I really want to highlight here is this, the take-home messages. While physical therapy is recommended in the management of postoperative cervical fusion, there's little consensus in the literature regarding specific treatment techniques and dosages. Treatment progression for post-op cervical fusion with persistent pain are also not clear in the literature. The authors in this study, including Darren, based their interventions on detailed assessment of the patient's presentation, symptoms, pain referral patterns, central sensitization, and functional limitations. And the authors progressed grade and time per bout of mobilization based upon patient responses and clinical reasoning. So this is the results again, and basically NPRS, 70 to 80% improvement, 38-point improvement in NDI, AROM 133%, AROM 100%, AROM extension 300, AROM flexion 50%, ULNT normalized, pressure pain threshold increases from 43 to 140, and the allodynia was gone. Central sensitization was abolished. I want to ask you, the Facebook Live audience, some rhetorical questions. Question 1, regarding your practice pattern. The question is, how does your philosophy of practice of assessment, intervention, and reassessment and progression compare to that of the authors? In other words, rhetorical question, how do you stack up to the PT LeBeau fellowship student? Question 2, therapist effectiveness. How do your patient outcome data compare to those of the authors and the patients you see 2 years post-op cervical fusion? Question number 3, when anatomy changes, theories may falter. Remember, C5-6 has been fused. So for those of you who like arthrokinematics and osteokinematics and biomechanical theories, if you find those as guiding principles, the question is this: do the arthrokinematic and biomechanical theories that applied to C4-5 above and C6-7 below the fusion, do those principles and theories that applied before the fusion at the adjacent levels? Are they now the same after the fusion? And then finally, rhetorical question number 4 and 5, use of manipulation. Remember, C5-6 has been fused. Question for you in the audience. Would you use thrust manipulation in the patient in this study? Can you truly isolate your thrust manipulation force to ensure that you do not damage or compromise the surgically fused C5-6 level? And refer back to question regarding potential changes in arthrokinematics. If the arthrokinematics have changed and your application of thrust is based upon an obligate arthrokinematic theory, then it may not be correct because the arthrokinematics have changed. And then finally, we need to think about the long term for this patient. Questions 6 and 7, what are the long-term post-fusion sequelae? Remember, C5-6 has been fused. What is the likelihood of adjacent segment degradation or disease or fusion disease at C4-5 above the fusion and C6-7 below the fusion at 5 years and 10 years? And how would you as a physical therapist advise the patient to minimize the degree of subsequent fusion? So I'm going to unshare that now and get back to our chit chat. And Daz, I just want you to give a little bit more. We've gone through the study pretty heavily. Just have a chat about it in general terms.
Yep. So the points I would make out of this study is that, first of all, you can palpate around a fusion. So you got to use your common sense. Probably 3 days after the fusion, I don't want to be poking around a surgical site. But this guy was 2 years post-fusion. As far as I'm concerned, he just has one big vertebra. And it's amazing how many therapists, like in my region, I've treated quite a few people with pain after a fusion, and no one will touch their neck because they're scared they're going to screw it up. And again, the reason they use instrumentation is to stop something shifting straight after surgery. It's pretty strong then. Once that bone fuses in, they don't even need the instrumentation. It's a big vertebra. I personally, and I'm a bit of a palpation skeptic at times, what drove us more was the comparable sign from what I remember. Because when I palpate post-fusion people, sometimes it hurts right on the vertebra which was fused, but that's the most comparable sign. I got no problem mobilizing it because it's one big vertebra. So I can't recall back then, but I have a feeling, certainly a lot of patients I see, I just mobilize where I get the most comparable sign. Sometimes it might be above or below, or it might be on that one big vertebra. Maybe it's got more leverage. I don't think I'm moving the fusion in any way. I am probably most likely changing above and below something, like a joint above and below is irritated because it's moving too much now due to the fact that it's taking up more of the range of motion, etc. But you could explain everything either mechanically, as in we change stiffness, but maybe it's a pain science. You could probably explain it with pain science, couldn't you, Shoei? You could say you've desensitized, he moves more into range now because he's not hurting as much. At the end of the day, I didn't really care. His head was moving more. He was getting less pain. He was feeling better, basically.
Yeah, well, as you and I have discussed, when you're doing joint mobs, and I'm not talking about fusions specifically here, you're doing joint mobs anywhere in the body, shoulder APs for a frozen shoulder. As you mobilize, you can feel the tension reduce. You feel R1 move out in range. To me, that's evidence of the neurophysiological effect happening. We're getting reduction in tone, we're getting reduction in resistance, and we're actually starting to be able to now go in and feel true joint movement and explore the joint movement. The other thing about fusions too, if the PTs on this call work in a hospital system where they have access to the surgical record, you can have a quick look at the surgical record and find out whether or not, and you're certainly not going to share this with the patient, this is for your own intelligence, you can find out whether or not it was a straightforward surgery and it went the way the surgeon expected it to, or if it became a lot longer and complex. A number 8 screw was used, but it was found ineffective. So the 8 screw was backed out and a number 10 screw was used with a plate and 3 inches of Kirschner wire. You can read in the surgical record whether or not it was straightforward and they're comfortable with it, or if it was a hard one. You know, if patients have variable osteoporosis, you drive those screws in there into the cortical bone, you may not get the grip you're looking for.
Yeah,
I
look at that 2 years down the track, mate. It should just be healed up, you know.
Oh, no, I totally agree. I'm talking about early post-fusion.
Yes, yeah. He can have increased sensitivity due to the fact that no one's touched his neck in 2 years, for sure.
Sure.
This is where
he's scared. He's terrified.
Yeah, and this guy wasn't too bad. I don't think the catastrophization thing was that bad with this guy. He just had flare up, and he was 2 years down the track, and he wanted us to fix it. So I sort of feel there was mechanical things change, you know, when we do manual therapy. I know there's a big debate at the moment. Again, I'm not that worried about it as long as they get better. And then it goes into the question of, did he remain better, which I think, did they do a follow-up with him a year later or something? I'm not sure, but that's the next question, which was the question that you sort of put forward with regards to how do you spare those segments above and below so that he doesn't end up wearing them out quicker, or he doesn't have another flare up. So,
well, that's where we have to go to motor control strategy and retraining of activities and postures. You know, if he said my lifelong wish is to be a bungee jumper, and now I'm 65 post fusion or whatever age he is, you say, yeah, maybe take up hiking instead. Don't go into bungee, and don't play contact football, you know, or contact ice hockey.
So
because
now
you might be compromised.
Yeah, absolutely. You've got to give them intelligent advice on stuff.
Right.
You know, the other thing I'm now looking at more when I watch neck patients, whereas previously I was more interested in range of motion, is how they move.
Sure.
The theory is that if you're sort of moving off axis as you rotate, whatever way, either flexion, rotation extension or rotation flexion, because you're not on axis, you're putting extra stress on areas that you weren't designed to put stress on. So why are they doing that? You know, often if you hear about this is another thing that I spend a little bit more time in my subjective on, is what people do during the day that doesn't, I always looked at what are your aggravating activities, and I would delve right into them, obviously, to determine irritability and stuff. But also I want to know what they do that doesn't bother them. You know, do they sit on the phone like this all day? You know, do we need to correct something at work so they're not in these postures? Because these postures result in you see it all the time, they result in movement patterns that fit what they do all day long, basically. Sure. So secretaries often, certainly back in the old days when they had the phone like this a lot, when you watch them rotate, they do that. They just go into that pattern because they're doing so much that certain muscles are getting weak and elongated, etc. So I would look at that guy at making sure he's aware of trying to get him back on rotation better, give him a series of exercises for that, look at his thoracic spine, give him advice. I look at scapular a lot now with necks because you know, you're hanging off, levator scap attaches, they're just hanging there. So often when I'm doing cervical range of motion, I elevate the shoulder girdle, and if range and pain change dramatically, I know I've got to address that. If it doesn't change much, it's more a localized problem in the neck. So these are sort of a lot of the things I picked up from the MSI approach, which I thought were good.
Right. No, absolutely. Absolutely. I mean, the manual therapy, I consider manual therapy effective at control, alt, delete, resetting the system, restoring normal movement. And then the whole next thing is functional motor control. That's what stops it from coming back. And that's when you see people who go to other manual therapy practitioners, no names used, who do a quick intervention and send them away and say, come back in 2 weeks. And they're just an annuity patient. They just keep coming back because they just keep buggering up their neck or their back or their knee or whatever it is, because you're not giving them the tools to properly manage the way their body moves, the education, the proper exercises, specific exercises.
There's certain patients, you can just correct their movement pattern and it offloads the segment and the pain goes away. But there are other patients that you correct the movement pattern, but if you don't clear out what got irritated due to this abnormal movement pattern or an injury,
just going to come back.
So it's nice having the manual therapy in your toolbox, which sort of brings us to this debate that's been going on forever, this hands-on, hands-off type thing. Exercise is superior to manual therapy or vice versa. It's just the dumbest debate in the world, in my opinion, because why would you, if you're a builder, want to throw out some of your tools? Why would you throw out your hammer because some guy on Twitter says hammers suck type thing? I'd be like, mate, when you need a hammer, it's good to have a hammer, So I think it goes back to the subjective. It goes back to sort of doing a good evaluation so you can work out when you need to use manual therapy. I don't always use it. There are some patients you don't want to use it because then they want to come in and get their little bit of a massage or whatever. But there are, what I'll say to these guys who say manual therapy sort of sucks, I'm like, first of all, if I get them better with manual therapy, even if you got them better with therapeutic exercise, why can't I do manual therapy? I got them better too, type thing. So don't tell me something sucks because I can just turn around and say, why are you using therapeutic exercise when you can get them with manual therapy? The second thing is, how are you going to apply specificity and dose to someone who comes in with chronic headaches? This is just an example.
Yeah.
And at C1, you light them up, they've got the headache. What exercise are you going to give them that gives them enough dose? You can sit there and retract and do all this sort of stuff. I've seen people that have done it all. They come to you, you do some unilateral PAs and you hammer away, clears them out. So why would I not want to have that tool in my toolbox? It's the dumbest debate I've ever heard. Similarly, if all you do is manual therapy, when someone comes in and they've got a movement impairment or they need more of a sort of psychosocial approach, that's a bit dumb too, isn't it? So
yeah, absolutely.
The way people have got so wound up over this debate, I'm just like, if you're even having the debate, you're missing the point, sort of thing. So,
well, it's about clicks. It's about clicks on social media, mate.
Twitter is all about being controversial because you'll get
outrageous and controversial.
Correct. It's a bit embarrassing as a profession, the way people carry on. When you think of, we're meant to be open-minded, reflective thinkers, all these things that Jeff Maitland
lifelong learners.
Back to Socrates. And then you're getting on Twitter and you're hammering some guy who's decided to do a running analysis on somebody and he's written a few things down and you're mocking him. To me, it's rude, obnoxious, and also it's not very open-minded, which you all reckon you're open-minded. I just laugh. I heard a debate recently between a very experienced McKenzie therapist and a guy who isn't. And it was just mind-blowing how the guy who was 50 was sort of referring to the research, saying it's not in the research. And the 80-year-old guy or 70-year-old guy who's been practicing longer than that other guy's probably been alive, sort of was going, but I've seen it, I've done it. And how you would think you've seen everything at 50 is beyond me. I sort of think I'm just starting in this profession and just sort of starting to understand things. So gets me going a bit, Chris, gets my blood pressure up.
Yes, I know it does. And I don't want to negatively impact your health status, mate.
Yes.
So take a little sip and, it's the nature of, the squeaky wheel gets the grease. And if you say something controversial and if you bag other people and make fun of them, but at the end of the day, those kind of people are not, they're bullies. There's a lot of bullying I see in that arena on Twitter regarding that issue. And hey, it's about clicks. People make money on clicks.
Yeah. I mean, I don't mind a debate. Keep it civilized is my thing. That's my, because the defense is that, you guys just can't handle a bit of criticism. I can handle criticism. Just keep it civilized. And there's no need to say things suck and all this sort of stuff. It's sort of not polite.
I see. Yeah. I was talking to Chad Cook the other day about this very issue, and he said, one of his favorite gentlemanly retorts when this sort of attacks go on is say, look, I apologize. You've got me at a disadvantage. You've read my research of well over 300 papers. I haven't had an opportunity to read your research. Could you identify to me where it is? Right. So, yeah, I understand. We're trying to wrap it up. So guys, we've got about 10 minutes left here. Do we have a good time to put some questions in and give Darren a chance to answer them, Darren and I? So pump out those questions on Facebook. Rosalie will let me know. In the meantime, so we talked about exercise versus manual therapy. Now, there's no, the science is pretty much rock solid on the effects of manual therapy. There is no question whatsoever on the effects of manual therapy. And I'll offer you 2 resources on that. One of which, this is going to sound like a promo, it's up to you. It's our Mechanisms of Manual Therapy course online on the MAPS website. Or you can go to the Academy of Orthopedic Physical Therapists and do their monograph series, which is Joel Bialowski and Carol Courtney, and they go through all the mechanistic effects of manual therapy. So to those people out there who say manual therapy has no mechanistic effect, it's not true. It's well validated. It has a mechanical effect. It has a biological effect. It has a psychological effect, and that affects the biopsychosocial. It has an anti-inflammatory effect, and it has placebo. And there's nothing wrong with placebo if it's used appropriately. Placebo can be incredibly powerful. So let's go away from that for a second, and let's talk about MOBs versus Manips, because that's the other hot topic of the last, I would say, 10, 15 years in the States. About
to me, it's the same debate. It's like they're both tools, and to throw one out would be sort of insane. And we both do them, don't we? Obviously,
absolutely.
But I've always felt that a manip is potentially more likely to flare or hurt someone than just a mobilization. It's like everything's good, bang, it's either good or it ain't good type thing. So why wouldn't you do the safe technique first? And if that works, you don't even have to go to the one that's maybe slightly higher risk.
I'll put it this way, okay? Why not use a graded mobilization where if you cause a negative effect, and it's probably just pain. I'm not talking about fracturing a cervical vertebrae or anything silly like that. If you reach a point where you get a negative effect with your mobilization, you can always back out of it. You can always reduce your grade. You can do the same mobilization at a lesser grade. Correct. Instead of a 3++, back it down to a 3+, or all the way down to a 3. But when you do a one and done manip, the outcome is the outcome, and it may not necessarily be the ideal. The literature is, there's a lot of literature these days. One of the things that's problematic in the profession now is terminology, spinal manipulative therapy. Well, it depends who wrote that paper. If that was a DC chiropractor, yes, they're using thrust. Other people use spinal manipulative therapy to mean mobilization or even some soft tissue work. So the problem is, I wish we now have to say, thrust manipulation versus non-thrust manipulation. Much cleaner in my mind, 35 years of doing this. There's mobilization, there's manipulation, and they're different things, and they're used for different things. In Jeff's response to manipulation, it's rarely used as the first treatment, used maybe about 15% of the time. Most can be done effectively with mobilization. And something to think about manipulation, repeated manipulation traumatizes the joints. You've seen patients in your clinics, Facebook Live people, who've come in, who have been to professionals who do a lot of manipulation on them on a regular basis for a number of years. And those patients come in and they are hypermobile patients. Yeah.
Yeah. I just look at the fact I've treated people who've seen chiros. I've treated the same level with MOBs. They get better. Flip side of that, I've mobed the hell out of someone, hasn't been getting better. Manipped them,
it works.
Better. So
Right.
we're not good at identifying, though, when the manip is, do you know what I mean? Like you're not sure when that manip's the one to pick. So start with a less aggressive technique, and then you've got that up your sleeve if it's appropriate, sort of thing. So that's just a clinical observation. So that's sort of my theory on the whole debate. And I think the science is showing that that's the case, isn't it? And manips, you know, for the amount of effort that you have to put in practicing to get good at it, you know, if I had a choice between being good at one or the other, I'll be a mobilizer any day of the week.
Well, and the other thing is, you know, the manipulation positions, whether you're using a Maitland manipulation, a Cyriax manipulation, a UK osteopathic, a Manel, a Stoddard, others, have different angles they do it at. Correct. So the manips are effectively different. Unless you know all those techniques, you're not going to be able to get that neck manip that has to be done at a particular angle. Whereas the mob, we can always change the angle to find the comparable sign with the least amount of force and then mob it there. And that angle changes. That changes throughout the patient's management because you cleared that part and now you get the next part.
I have a question.
We have a question. Go on, Daz, talk for a second. What's the question?
Travis has a question, and one thing the question he has is some good subjective cues to think functional movement versus passive treatment to guide your objective hypothesis.
So question from Travis. Some cues in the subjective exam that you used as to help guide your, going up, say again.
Functional movement versus passive treatment.
To help guide functional movement versus passive treatment.
To guide the hypothesis.
To what?
To guide your objective hypothesis.
To guide your objective hypothesis.
I use the examples of, I think I'm understanding what he's saying. He's sort of looking to see why do I bend towards more Therex versus a manual therapy treatment.
Sure, that'll work.
You know, the history, you know, I've had this problem for, like my runner, I've had it for quite a while. It comes on at the 5K mark. You know, there was no specifics. Well, he fell off a stool, so I sort of was a mixed sort of picture there. But like if you step in a hole and you sprained your ankle, I would think I just need to guide you through your healing process. And actually, you would combine both, wouldn't you? You could get your hands on there and do some Therex. But if they're more of a sounds like a movement impairment person, so they're telling you there was no specific injury, they can't explain why they have the pain, it's a bit more chronic, it comes on with a repetitive sort of activity, I might bend towards thinking, well, maybe I need to look to see if there are imbalances that need to be corrected, versus if I delve into some of the psychosocial questions, I bend that way. So there's sort of the cues that sort of, generally, if you hear the whole story, it's common sense, you know. It's they sound like they're going to respond well to manual because it was a fresher. Well, I shouldn't say fresher injury because chronic people respond as well, but the history has a lot.
Well, I think the key take home as we wrap it up is that you have to do a decent assessment.
Yeah, everybody's so different.
Objective. You got to do it. There's no shortcuts on finding the information because the information guides your clinical reasoning, helps you develop your clinical hypotheses, which you then test in your physical exam. I do have one comment on your bloke who fell off the stool.
Yeah.
Did you try putting, so one of the first things that pops into my mind when someone says, you know, I only get my pain in my back at the 5K mark. I would throw them on a treadmill and say, all right, run 5Ks and get straight and tell me about your pain, get them straight off the treadmill and then take a look at how they move.
Well, so you do that. Let's say he starts hurting. You go in and palpate. You find a joint that's flared up. In my hypothesis testing, I'd still be like, why is that joint getting flared up? He's probably. Oh no,
I'm still in movement science. I'm not. Right. I don't even want to treat him at this point.
Well, you don't even have to do that. To be honest with you, well, Shirley didn't. She's sitting there slapping me the whole time, going, "You see that?" And I'm like, "What?" You know.
Well, that's because she's a legend and you're not.
Mate, she watches people walk in the door and has them nailed, and you have to take an hour and you still don't know what's going on. She is unbelievable. She's a savant. But interestingly enough, she does her whole evaluation, and but with that guy, you you can correct these impairments without necessarily reproducing their pain, but it's
Sure.
a thought process to go through for sure.
Sure. One more question, I think, Daz, and then we'll wrap it up. What's the question?
Daniel asked, could a quote roller coaster report of good days and bad days lead towards decreased neurodynamic control?
Daz, the question is, could a roller coaster, what was the name of the questioner?
Daniel.
Daniel asked the following question. Could a roller coaster report of good days and bad days lead you to think about what?
Decreased neurodynamic control.
Decreased neurodynamic control.
I don't.
I'm going to paraphrase that as motor control strategies.
Yeah, I would. Yeah, I'd be thinking more pain sciencey stuff, because there'd be a consistent. I mean, it depends what's going on the roller coaster days. Are the days when he's all flared up and not doing well? Is he doing a lot more activity? In which case, yeah, motor control, whatever, could be part of the problem.
Yeah.
If the guy's just never changing anything, and he's going up and down, up and down, up and down, I'd be asking a lot more questions, trying to work out why that is. I mean,
might be beyond the tissues, mate. Yeah.
Well, beyond the tissues, changes in weather, things like that. Stress levels. Yeah, absolutely. You know.
Yeah. Well, then we end up in the biopsycho, right? Then we end up,
possibly,
and that often leads to really interesting places. Some of them quite tragic, as people tell you their story. You know.
But so I always ask them, when you go on vacation, does it go up and down?
Right.
And if it doesn't, again, it might be their job. That could be a stress thing. But think about it. If every time he's up, it's like, oh, that's when I'm doing this particular thing at work. So
it's an ergonomics issue, right? Yeah.
It's subjective. You just got to ask a lot of questions. You're a detective, and good detectives always ask a lot of questions that the bad detectives never think of asking.
Sure.
Like Columbo, he always did that.
Good way to wrap it up. So thank you, Daz, Darren Earnshaw. Really appreciate your time tonight. Thank you, everyone, for joining in. And just a quick reminder that we're going to put this up on the research commentary page on ozpt.com, so you can re-watch this. And I think we should do another one of these. What do you think, Daz? Who do you nominate? You as the reigning king, you get to nominate the next person.
I think you should get. That could be controversial. Mike O'Hearn.
All right, Mike O'Hearn. You and I put some pressure on him. Yeah, and we'll put Michael on for next month with a bit of luck.
Yeah, he's super interesting. The way he has a lot of information that, like, I don't bother with PubMed. I just call Mike. PubMed. Yeah.
Mike Med.
Yeah.
All right. Good night, everyone. Thank you very much, or good morning, wherever you are in the world. Appreciate your time. We're going to stop our Facebook live share here and wish you all a wonderful afternoon, evening, or day.